Hi, I'm Vic Veer, and what I want to do is start off with a little story, if I may. After finishing my first 5 years at medical school, I spent the next 15 something years training to be a surgeon or a consultant surgeon. I think the Americans would call me an attending. Anyway, I'm the head of the sleep surgery department at the Royal National ENT Hospital in central London. But what I noticed was all the way through my training, and I did respiratory medicine, neurosurgery or brain surgery, heart surgery, all types of different surgery. But nearly everyone said to me that the treatment for obstructive sleep apnea was CPAP or a CPAP mask that you wear at night. And whenever I mentioned that I met someone who wasn't able to use the CPAP mask and what else there is there out there, the most common response would be, oh, well, they're just fat and lazy. Just tell them that you'll take away their driver's license and say that they will die if they don't use the CPAP mask. So it seemed to me that the perceived wisdom was that it was somehow their own fault and they should be punished for their behaviour. And even now, even in my theatres, I see people coming up to me and saying, well, these guys, they just need to lose weight, don't they? And it just really upsets me because, I mean, the evidence points now towards obstructive sleep apnea being the reason why people gain weight, not the other way round. And so, again, this whole culture, this whole belief system that obstructive sleep apnea is somehow their own fault, the patient's own fault, and it's up to them to sort it out. It's not really a problem that we need to deal with. I've done a lot of videos like this on this YouTube channel before, but they're all in little bits all the way through. So some people understandably look at only one or two videos on my YouTube channel and they go, oh right, you're that doctor that doesn't like to operate and just can fix people without any operations and without a CPAP mask, which is not true. Or people come up to me and say, oh, you're that surgeon, all you have to do is do this operation and everything's cured. Again, that's not quite true either. So what I want to do is explain how I look after people with obstructive sleep apnea in a sort of summary way so that you can see exactly what my process is. And hopefully you'll understand more about how I think sleep apnea should be treated. Almost the first thing I do with all my patients is organise a sleep study. A sleep study is a machine that sort of sits on your chest here with some straps, a little thing up your nose, a little monitor in your finger, and what it does is it monitors your oxygen levels, your pulse rate, your brain waves, see what stage of sleep you're in, how much effort you're using to breathe, all sorts of things, and that will give me a 1 to 3 nights snapshot of your sleep. That's really useful because firstly, a lot of people come up to me and say, look, I'm just a snorer. My wife's really annoyed with me. Please just fix the snoring. And often I say to them, look, we need to do a sleep study just to prove that you're just a snorer. Because on the most part, the vast majority of people have actually a sleep breathing disorder. So that means they have obstructive sleep apnea or one of the other breathing disorders that causes the snoring rather than you only being a snorer. Normally, I do my sleep studies in your own home, in your own bed, because I think it's more representative of your own sleep, because you could just drag everyone into hospital, get them to sleep in a central London hospital, but the problem is central London is really noisy and it's not your own bed. I think a lot of people notice that when they go on holiday for the first 2 or 3 nights in, I don't know, the Maldives or something, you think this is going to be the best sleep I've ever had on their first night. But it's hard to get used to a new bed and new surroundings. It takes about 2 or 3 nights to get used to a new bed. And the same thing happens with obstructive sleep apnea or any type of sleep. If you have a sleep in a strange bed in the centre of London next to a pub or something, you're going to get bad sleep. So I like to do sleep studies in your own bed at home. Now, just based on the numbers that I see from the sleep study, I can give some people some advice of, like, for example, actually, you really ought to sleep on your left-hand side rather than on your back or on the right. And there are lots of reasons for this. Or I can say, it looks like your nose is blocked. Are you sure your nose isn't blocked? And little things like that I can work out just by looking at the numbers. But that's kind of not that useful for me because I want to know exactly not how bad you are, which is really important, and that's why we do the sleep study in the first place, but really where the problem is. Why does this person have obstructive sleep apnea compared to another person who doesn't have obstructive sleep apnea? What's going on inside their throat? What's causing this blockage? And so the way to do that is not look like if someone looked at my nose now, if I had obstructive sleep apnea, you wouldn't see anything because the person's awake and they don't have snoring, they're not stopping breathing, they're not going blue. You need to catch someone when they are sleeping. And I think that's really important. I know a lot of doctors don't do this, but I think it's really important because the way I do it is I get someone to lie down on the bed and I give them a touch of sedation so they start snoring away in front of me. And at that time I can use a tiny little microscopic fibre optic scope to look at the back of their throat, so I can see what's happening to the nose, is the nose getting blocked up, or where in their throat the noise has been generated from, because you can see the flutter of the parts of the throat, and where the blockage is coming from. So you can see the tissues narrowing down and blocking your breathing. Now, a lot of people think actually everyone snores from the same place, everyone stops breathing from the same obstruction. That's not true. Actually, nearly everyone is very slightly different, and trying to work out where the problem is really important, because, for example, I'm a surgeon by trade. I don't want to do all 40 something operations on someone until I get the right one. I don't like working by trial and error. I like to pick out the right operation for the right person. Or, for example, if I said to someone, look, maybe you should try this device, and they go off and try this device for 3, 4, maybe 6 months and come back to me and say it didn't work, it seems like a huge waste of their time and also NHS resources, because I do all of this stuff for free on the NHS. So all you need to do is come and see me at the Royal National ENT Hospital. Just ask your GP to send you to me. So anyway, I look at the back of the throat, take a video of the inside of their throat and show the patient where the problem is. When you see it, you can see everything blocking off. It makes a lot more sense. And then a lot of people realise actually it's multiple areas of blockage. Now, nearly everyone has multiple areas of blockage, because if your airway could be blocked off by one thing easily, then I don't think we would have lived, we wouldn't have got this far in our evolution, because we would have all died off pretty quickly, because our airway's got lots of redundancy, lots of fail-safes and things like that. Although it does sometimes happen, it's quite rare. A lot of people think, oh, it's just my tongue falling back. It's quite rare for you to just have a tongue-based problem. I think roughly about 6% of people have a tongue-based problem only, whereas if you look at it, well, I've looked at my patients, about 50% of people do have a tongue-based problem, but they also have other things as well. So there's not many people that only got one problem. So they might have a tonsil problem, epiglottic problem, lateral wall problem, all these things I talk about in my other videos on my channel. Anyway, so we need to work out where the problem is and what their individual combination of problems is and what proportion there are for each of them. Another good thing about watching someone sleep and look at the back of their throat is that you can try different devices on them, like a mandibular advancement device, it's like a gum shield that goes in your mouth. It brings your jaw forward ever so slightly. That's great, because then I can say to someone, look, when I put this thing in your mouth, you could breathe an awful lot better and you don't need an operation by me. You could just have this device and that will be the end of it. And I also worked out that you need 2 millimeters advancement, or 3 or something like that. And then they can go away, see a good dentist that can make one of these devices. And the same thing can be said for INAP devices or tongue retaining or anything you like. We can try these devices out whilst you're sleeping. I can work out what would work for you and what wouldn't work for you, so you don't have to do trial and error at home either. Also, at this initial stage when I'm trying to work out what's wrong with someone, trying to get a picture of their sleep and what their problems are, you can do some blood tests as well, particularly if people are very, very tired. They could do things like B12, vitamin D, zinc, and all sorts of things. Actually, I'm going to do a new video on that, which will explain all the things I check for and all the blood tests and tests that I do, but I'll leave that for another video. So once you've done all the investigations, the sleep study, the drug-induced sleep endoscopy, the blood tests, you have a better picture of what this person is like and what's causing their sleep problems. And now all you have to do is work out how you're going to treat this person. So what I'll do is I'll start off with a sort of common scenario. Maybe we'll choose a 55, 60-year-old woman who's just gone through the menopause. I think a lot of people now know that women who've gone past the menopause start snoring and having sleep apnea as much as the men do, because they don't have that hormonal advantage they do before the menopause. Estrogen keeps your tissues sort of stringy and elastic. Now, this lady may for many years have had a house dust mite allergy, which is causing her to have a hot blocked nose at night. It didn't really bother her, but now other things are causing a problem, because again, she might for many years have had relatively small tonsils, and these tonsils often meet at the back of your tongue. So a lot of people think that tonsils are discrete little meatballs in the side of your throat and they don't really do very much after puberty. But what happens is that actually you do have these palatine tonsils, those tonsils on either side of your throat, but they do grow on the back of the tongue. So your teeth are here and the tongue coming down like this. You've got a tonsil there and a tonsil here on either side of the tongue, but they do grow over the back of the tongue where this tongue's coming down there. And that makes a different type of tonsil. As we name it differently, but it's actually probably the same sort of thing. So it's the palatine tonsils left and right, and on the back of the tongue it's called the lingual tonsil. So she may have already had this for many, many years since puberty. Again, it wouldn't have bothered her. But now that she's got a blocked nose and her menopause and her hormonal advantage is gone, and so what's happened is things are starting to slack a bit. So when she's lying on her back particularly, her jaw might slacken back a little bit and her tongue may fall back. Normally that doesn't affect many people, but because she's got an extra bit of tissue on the back of her tongue, she starts blocking off her breathing. Now, with all of this stuff going on and causing obstructive sleep apnea, she will slowly start gaining weight as well, because sleep apnea causes weight gain, not the other way around. And then this person ends up coming to me because they're desperate and they can't get themselves out of this horrible vicious cycle. And we need to work out what to do at this point. Now, obviously, one operation is not going to get rid of all her weight and sort out the nose and the throat and everything in one. That's never going to happen. So it's a process. And what I like to do is look at all the non-surgical things first and try and get this person as well as possible before you even consider any operative things. So, for example, with her blocked nose, I'd say, well, why not try cutting down the amount of house dust mite from your house? And if you need to, try some steroid sprays to try and unblock your nose. Again, I'll talk about that in that other video. Next thing you can do is try and get rid of all those vitamin problems. Add some iron if she's a little bit anemic because she's had irregular periods, we're not sure. So all those things we should do first. I also suggest, look, you've got moderate to severe obstructive sleep apnea. You really should start using CPAP. That will work really well in about, I think, 20% of people. A further 50%, I think, struggle with CPAP. So those 20% of people at the start absolutely love their CPAP and they go, look, please don't ever take this away from me. It's the best thing that's ever happened to me. This is great. I don't know why anyone complains about this. This is wonderful. A further 50% of people, I think, use it because they feel like they really have to, but they find it very hard. It sort of leaks and things like that. And reliably, about 30% of people can never use it. They find it really hard to use, even in controlled trials where lots of technicians are trying to help them get through the trial so they can show the best possible results. Even those situations where people are speaking to them every day to help them, they just physically cannot use CPAP. So let's say that she's in that middle 50% and she's trying to use it, finding it very hard because of air leaks and things like that. It may be because her nose is very blocked up. So even though she's using the sprays, it still gets blocked up and there's nothing she can do about it. So what I often say is, look, why not do a small operation on the nose just to shrink down the turbinate, say, or something like that, and open up her nose so she can use the CPAP. That operation takes, I'm guessing, about 10 to 15 minutes, depending on what the situation is. It can be longer if your nose is slightly twisted, but I'll look at my channel for those sorts of questions. Anyway, so once I can get someone to use their CPAP, that puts them in a lot better situation because then they can start losing a bit of weight and feeling healthier and not being so tired during the day. I noticed that I said that once you start using CPAP, you can start losing weight because you're no longer stressed anymore. A lot of people find when they're using CPAP, they can suddenly lose the weight that they've been trying to lose for many, many years because diets actually start working once you're treated for obstructive sleep apnea. And sometimes the weight just falls off. It's great. Anyway, so they're starting to lose some weight, they feel better, they feel more energetic, they don't feel like they have to constantly eat carbs all the time because their sleep pattern is a bit better. There are some people, however, who still struggle, and I'm not the sort of person that says, well, you have to use CPAP before I do anything. I do say that if you want to have an operation on your throat and something, I'd really like it for you to use CPAP for at least 3 months prior to an operation, and I think that's really important. The reason why is that if you don't use a technique or some treatment that helps your obstructive sleep apnea, then you officially have untreated obstructive sleep apnea. And when you have that, the risks of an operation are much, much higher. Some people get strokes and heart attacks, and the surgical success rate is much lower because sometimes I explain it this way. If I'm taking bits out of someone's throat and reattaching or stitching things up, how's any of that going to heal if no oxygen is getting there? If there's no oxygen getting to the tissues, it's not going to knit together no matter how many stitches I put in there. So it's all going to start falling apart. So it's really important to try your best to use CPAP. I'm saying that if you can't use CPAP, I will still do anything I can to help you, because you do need something to get you vaguely treated so that you can start feeling better again. So for argument's sake, let's just say that this lady wasn't able to use CPAP very well at all, maybe 4 or 5 hours each night, and that's all she could manage, which is fine. It's better than nothing. And what I say to them in this situation, look, I don't really want to do a huge operation because I'm worried that it'll be too much stress for your body. Maybe you should do a small operation, something that improves your sleep apnea by a smaller chunk. And then looking at the drug-induced sleep endoscopy, I say, well, you did have slightly bigger tonsils and your tongue base was quite big. What we have to work out at this point, which one was more of an influence on their breathing? Was it the tongue or the lingual tonsil, the tonsil tissue sitting on the back of the tongue? Was it the size of the tonsils that causing the problem? And then I'd say, look, actually, I think in you, maybe we should do a 10-minute operation, remove your tonsils, and then don't do anything else. That will hopefully bring your AHI, or the number of times that you stop breathing every hour, your sleep apnea levels down a little bit by, say, 30-40%. You will feel 30-40% better after this operation. You won't be cured, but you'll feel better. That will allow you to lose a bit more weight, maybe even use your CPAP better because the pressures will be less and you won't be leaking so much. You'll be able to use it better. You will feel correspondingly much better, and then we can go on to the next operation if you want it. And so we keep doing that. We do an operation, people lose a little bit of weight, it plateaus off after about 3-4 months, and then they say, look, I'm not getting much better and I still want to feel better. And then, okay, great, let's do the next thing. Maybe we'll go tackle that tongue that we knew was a problem. Then we'll do the tongue base, bring it down a little bit more, they lose a bit more weight, they feel better, they use the CPAP more, until we get to the point where we think, maybe we should come off the CPAP, because actually, once you've done a sleep study, I've noticed that you're not bad enough really to use CPAP anymore. We can try and come off that, make your life a little bit easier. And you can see what I'm trying to show is that this is a process. We're slowly edging towards normality. One operation isn't going to fix anyone. You can sometimes have massive tonsils, and that's the only problem you have, and that's typically seen in sort of young men or women, age of about 20 or something. If you've got massive tonsils, it's a no-brainer. Just take the tonsils out. And a lot of people, it's coming up to about 90% cure rate at that point. But a lot of people, when they come to see me, have multiple issues. And that's what I'm trying to explain. We slowly edge people back to normality so they can slowly get back to where they should be in their same sort of peer group. Now, a lot of people watching this video right now will be thinking, he hasn't mentioned anything about snoring yet, and that's what I'm really interested in, which makes sense. A lot of people come to see me and I say, look, you've got this obstructive sleep apnea, your life expectancy is now between 58 and 62 years old, and you're likely to have a stroke or a heart attack in the next 5 years if you don't get treated. And people have said, well, what about my snoring? Which is understandable. Psychosocially, this is really important. They don't want to upset their partners. They want to be in the same room with them. Their relationship with their partners is really important. But I think a lot of people don't really understand that snoring, although it's important, fixing the sleep apnea first often sorts out the snoring, because snoring is more of an airflow problem. So, for example, everyone has a palate. Everyone has that dangly thing at the back of your throat, the bit that flaps around like this. And often that's the area where people snore from. But why do some people snore and some people don't? And it's normally because of an airflow problem. Either they've got a blocked nose, and if anyone who has a blocked nose ends up snoring, because if you've got a cold or a flu, everyone snores for a while until the cold and flu goes away and they stop snoring. And if you have, say, a tongue-based problem, which is a blockage underneath that dangly thing, and a blocked nose, you need to sort out both of those. And when you sort out the airflow, so the flow of air going through your airway is laminar, so it's like a smooth flow of air, like over a sports car, then normally the snoring just stops by itself. The thing that causes snoring is the turbulent flow of air through your nose, through your throat. And so when the turbulent air goes past the palate, because it's quite close there, it starts flapping away like this. And that's why people snore. It's just because the palate is flapping, there's no real need to go in there and start attacking the palate and stop it from fluttering. It may work for a short time, probably sort of 3, 4, maybe 5 years if you did some operation on the palate, but it's not a long-lasting thing, because you still got the blockage in your nose and the tongue base and that person I just talked about. And if you don't sort those things out, eventually that palate will start flapping again, and then you'll come back asking for another relatively painful operation on the palate, hoping that that will cure this problem. But it won't, because it's just temporarily stiffening it up and not sorting out the actual problem, which is the airflow. You need to sort out the airflow first. And then if you're still snoring, there are lots of little techniques that you can do for snoring on the palate that stops it from flapping around. But typically, as I said, stop the obstructive sleep apnea first and the snoring just goes away. So once patients have gone through this process where they're slowly coming down and their AHI is coming down to normal, I go to them, well, I think, your AHI is less than 5 in the supine and non-supine position. You seem to be well. I think officially you're cured, and I sort of explain what cure in obstructive sleep apnea means in this video here. But the problem I'm trying to sort out is that they feel better, as well as that the numbers look good, because there is a bit of a problem between the two as well. A lot of people say, I've been told that all my numbers are good, but I still feel terrible, and they might have like upper airway resistance syndrome or some other issue. And it's because people don't look at their sleep study properly. Again, another video, if you look at this video about how to read or interpret your own sleep study, you'll see that a lot of people miss things on sleep studies. They just look at the AHI. The AHI is a rubbish number. But if you interpret it well, you can sort of see where issues are when it comes to trying to work out why you're so tired and why the numbers don't fit in with how you're feeling. And there's again another video which I've done a questionnaire which sort of helps you understand how bad your symptoms are, so you can explain this to the person in front of you. A lot of people use the Epworth score. The Epworth score doesn't work. It's rubbish, because a lot of people don't just feel tired when they drive and things like that. So again, that's the other reason for that stamp score that I was telling you about. Now what I want to do is try and tie this all in with what I said at the start of the video, saying about, well, CPAP doesn't seem to work for everyone, and there are lots of reasons for that. What I'm trying to explain, the reason why I do it this way, is that I do all my investigations and try and work out where the problem is, as well as how bad the problem is, before I give someone treatment. Because what will end up happening is that you're given CPAP and then you find, I can't use it. I'm one of those sort of 30% that can't use it at all, or 50% of people who find it very difficult to use. And then I say to them, well, people then will be told, look, why don't you use a mandibular advancement device if you can't be bothered to use CPAP? Which is quite depressing to be told that, because a lot of these people really try and really want to get themselves better. So they try a mandibular advancement device, and it may hurt their jaw and it may not be good for them. If it works for them, fantastic. But there's another subpopulation that find that difficult as well. And then they go, right, I've been doing this for like a year and a half now. You've given me CPAP. You told me to lose weight. I'm not getting anywhere. What can I do next? And so, well, you're not trying hard enough. Or, what people end up doing is being passed around from clinic to dentist to other medical profession, and they go down this sort of ladder, which I guess works in a way because you don't have to think too hard. You just you get a sleep study, you get a CPAP, you get a mandibular advancement device, you lose weight. That's the route that people seem to be going down, which, although is what a lot of national guidelines say you should do, I don't think it's right, because during that period where they're going through this process, people are struggling. People are getting really bad sleep, and they're not being, and they're told frequently that's all your fault, and you should be, trying harder, and all that sort of thing. And when a doctor says to you, "Oh, look, you're just too fat, and you're not trying hard enough," it can be really depressing, particularly if you're tired and you've had enough of this, and you're gaining weight and you feel awful. And no wonder a lot of people just sort of step away from the medical profession and say, look, I've had enough of this. No one is helping me. I think I'm just going to just live like this. And it's awful for these people. They've got untreated obstructive sleep apnea. They're going to go through so many problems later on in their life. We should not be doing this to people. So what I really want to say is that I'm truly sorry to all those people who've been through this, where the medical profession has basically let them down. And I'm really sorry. I do want you all to come back to us on the NHS so we can try and help you, because we shouldn't be saying that to patients that, just try this and it's all your fault. And we shouldn't be pushing you down this route where you're trying one thing after the other. Eventually something will stick and work for you. The reason why I put my process together is that I want to try and work out what your problem is by doing all the investigations, how bad you are, where it is, all those sorts of things. And then when I've got the whole picture, only then picking the right treatment for you. Admittedly, this isn't part of the national guidelines. The national guidelines still say you should try this, then try this, then try this. But during that period, you're getting really stressed and tired and overweight and just depressed. And so that's what I think people should be doing in the future. I think we should all be looking at this as a diagnostic challenge and then giving the right treatment. Because if everyone's going down this sort of pathway, everyone has CPAP, mandibular advancement device, whatever, then why do you need doctors at all? I mean, no wonder people are just going to Google and not trusting us. If everyone knows that, well, all they're going to do is get me a sleep study, I can get that myself. Then the CPAP, well, I guess I could do that myself. Why'd I have to wait for the NHS? And after that, they'll say, oh, you could see a dentist and get this. So why not us be proper doctors and get in there, try and work out what the problem is, get a diagnosis, find out exactly what's going on, and then give the right treatment. I'm going to start ranting if I keep going like this, so I won't do that anymore. But that's what I want people to do. And when I first started this job as head of sleep surgery at the Royal National ENT, I thought to myself, if I could get other doctors to change their perception of obstructive sleep apnea patients and get to the point where they're thinking, no, this isn't their fault and it's not because they're fat and they're lazy, that they actually have a problem and that we are around to help them, and that's our job, to help patients. And then they really think about it and say, well, actually, you've got big tonsils. You really shouldn't be having a CPAP mask because the national guidelines last year says that you should get your tonsils out first. Or you've got a really blocked nose. No wonder you're finding CPAP difficult. Let's sort that out. So if you look at a person in their entirety, or in a sleep sort of entirety, then you can try and work out what's the best treatment for them first and work with them to get them to the point where they're better. It's not an easy fix, and I've tried to explain that in this video. It's a process which can take some time, year and a half, something like that. But I think if you're engaging with patients and trying really hard to help them, people will respond to that, and it'll be a fulfilling, rewarding job, and you can see people being helped every day, and it's just, I'm biased, but it's one of the best jobs out there, I'm sure. I better go. But thank you very much for watching this. I will do some other videos, but hopefully this video will help you understand the process and why I put this process together to try and work out how to help these patients. And I'm babbling now, so take care. Thank you very much. Bye-bye.